So we're going to talk about insomnia today. So I don't have any disclosures or conflicts with this topic. I am going to be talking about therapies for insomnia that are not FDA approved. So talk a little bit about what is normal sleep. And, I think if we ask people around the room what they thought normal sleep was, we probably get a variety of answers. But technically, normal sleep, we'll get into in a minute, but then we'll go on and discuss what actually constitutes insomnia, the different types of insomnia. We're going to briefly touch on the epidemiology of insomnia, how we diagnose it, and then a few words on treatment. I decided, because more and more patients are coming in with their Fitbits and Apple Watches and telling me about their sleep based on these devices, that I'm going to spend a little bit of time talking about the role of these devices in evaluating patients with insomnia. So hopefully that'll be kind of exciting. So normal sleep, we say is 7 to 9 hours of sleep. When we look at it on the sleep study in the sleep lab on polysomnography, we see that people who are normal adults have 50 to 60% of their sleep time in light sleep, which we call N1 and N2 sleep. About 20 to 25% is deep sleep, the slow wave restorative part of the night. And then a similar percentage is REM sleep. REM sleep, of course, is dream sleep. The brain is very active during REM sleep, but the body is actually very silent and paralyzed. And, when we're talking about insomnia, we're asking, it's really a subjective complaint in many ways, right? It's really patients complaining either about the quality of their sleep, the duration of their sleep, or the continuity of their sleep. And we'll talk about that a little bit more. So a survey that was done and published in the MMWR a few years ago was a large group of people living in the US and just answering some basic questions about their satisfaction with their sleep. And you can see, surprisingly, like 2/3 of the patients said they reported healthy sleep duration as however they wanted to define it. And actually the best state for sleep reports was South Dakota. And interestingly, the worst was Hawaii, which may have, there may be some reasons for that in terms of sunlight and things like that. DC was right about average, and the healthy sleep duration was lowest among non-Hispanic African Americans and Native Americans, including Hawaiian natives. So how do we, when we talk to patients, what are we talking about when they complain about their sleep? So there's acute insomnia, and I'm sure everyone in this room has had episodes of acute insomnia, a day or two where you don't sleep well. Again, you feel that the quantity or the continuity of your sleep is not so good. That's usually triggered by some situational event, perhaps a medication, perhaps you threw your back out and that's what's preventing you from sleeping. But those are acute insomnia type complaints. Intermittent insomnia is acute, but repeats itself, right? But it's not a long-standing problem with sleep continuity. And so we define chronic insomnia, and this is based on our American Academy of Sleep Medicine definitions, as dissatisfaction, as I said, with the quality, duration, or continuity of sleep that's been present for at least 3 months and occurs at least 3 nights per month. So that's our sort of technical sleep world definition of chronic insomnia. And that's different from another phenomenon that we see, which is short sleep duration. There are people that sleep 6 hours and don't complain about that, right? They feel energized. They feel like the continuity of their sleep is okay. Those patients we characterize as short sleepers. Insomnia is really a subjective set of complaints, as I said. And again, when we use the ASM definition, we're talking that it's present for 3 months and occurs at least 3 nights per week. So other surveys that have been done, a large range of complaints with sleep satisfaction, 5 to 50% of the adult population. If I asked people in the room, how satisfied, are you very satisfied with your sleep? How many would raise their hands? Me and Dr. Kuru. How about not satisfied at all? Small number. Okay, so there's a wide range of how people perceive their sleep satisfaction, but probably really true chronic insomnia per that ASM definition is more in the 6 to 10%. But that's a lot of people, and I'm sure in your primary care rotations in the clinic, a lot of patients come in complaining of sleep issues, right? And you're like rolling your eyes, oh my gosh, what am I going to do about this? So, 6 to 10% of the population probably does have chronic insomnia, but the complaint is much more than that. And it is true that women are at higher risk for chronic insomnia than men, about a 1.4 to 1 ratio. It's more common in middle-aged and older adults. Shift workers, which is like the topic of another talk, really have a lot of trouble with chronic insomnia because of changing shifts. Clearly, patients with coexistent medical problems, patients who are of lower socioeconomic status, and also people that live alone tend to have worse or more sleep complaints with regards to insomnia than those that live with others. This is some prevalence data from the National Sleep Foundation Sleep in America poll that showed that you can see here the distribution of prevalence across ethnicities. But again, back to that issue, like people perceive this differently. I mean, in some worlds, it's like, like in our world, right? Less sleep is sort of valued as like, hey, I'm working real hard and I can push through this and blah, blah, blah. Where other people sort of fall into the insomnia track because, their parents are bugging them because they sleep 10 hours and they want them up less, they want them up more, So there is definitely issues and stigma with either too long a sleep or too short a sleep that plays into people's perception of their sleep and their processing of experiences. So, it's a unwelcome experience of difficulty sleeping. The problem is we don't really understand it very well, why patients become insomniacs from sort of a neurochemical or neurologic point of view. There's a lot of debate about possible paradigms of why people develop insomnia. One is this attentional bias. They have a bias in perception and processing of stimuli, which is kind of like ruminating about the day's events or various things that happen in people's lives that transfer into nighttime poor sleep. There's also another thinking that failing overnight amelioration of distress, like again, not being able to turn off the events of the day, result in this persistent sort of hyper arousal state. But, we don't really have like an endocrine explanation for this or a neurologic explanation. It's really a sort of a compounding of different factors that usually result in insomnia. So generally, there's some predisposing event that may occur that sets this off. And then there's a precipitating event and perpetuating factors. And this, hopefully you can see it pretty well. The precipitating factors, perhaps there's genetic reasons why people are predisposed to insomnia. We don't really know those yet, but perhaps there are. There's probably some people are predisposed because they have circadian rhythm issues. They're dysregulated in terms of some hormonal control of the usual circadian rhythm. And some patients perhaps have insomnia because they have certain personality characteristics. And these precipitating factors sort of lead into being exposed, if you will, by perpetuating factors like stress, hyperarousal, cognitive cortical dysregulation, and also by behaviors, right? So people tend to compensate for difficulty sleeping often by napping during the day, and that just sets up the cycle to repeat itself at night, and other conditioning factors. And sort of all of that stuff comes together, gives the patients chronic insomnia. And then the perpetuating thing is it's like a vicious cycle. Like the more it happens, the more it happens. People are just conditioned now to have difficulty with their sleep. So a lot of how we deal with insomnia is trying to break this cycle thing. People are perhaps born to be insomniacs, but then we have to work on these precipitating factors and perpetuating features that put it into a lifelong disease. So how do we make the diagnosis? Again, The patients come in and they're complaining either of difficulty starting sleep, difficulty initiating sleep, difficulty maintaining sleep, or waking earlier than desired. And, how many times have you heard patients say, I wake up at 2:30 a.m. every night, right? They just can't sustain their sleep through the night. And then they wake up, they ruminate about the fact they can't fall back to sleep, and this pattern then repeats itself. Some of the associated complaints of insomniacs are fatigue and malaise. They're usually not hypersomnolent like our other type of sleep patients, like sleep apnea patients. Sleep apnea patients are falling asleep here in the audience, right? Or they're unable to maintain wakefulness, and they usually fall asleep very easily at the beginning of the night. This is not that. This is fatigue, it's malaise, it's tiredness, but it's not overt hypersomnolence. People also complain of poor attention, difficulty concentrating, impaired social interactions, mood disturbances, reduced motivation, poor work performance, propensity to have errors, and just generalized dissatisfaction with their sleep. Now, to put it in perspective, I think everybody who sees patients with medical problems, there are risks in sort of all of our subspecialties or organ systems that put patients at risk for having insomnia. And I think it's probably a little bit underestimated in the cardiac world. Patients with chronic heart failure have a higher incidence of poor sleep. Obviously, our pulmonary patients who have uncontrolled asthma or uncontrolled COPD or even chronic cough will complain of difficulty with sleep. In the GI world, right, our GI friends should recognize if untreated reflux, aspiration, obviously hepatic encephalopathy is very disruptive to sleep continuity. In the rheumatology world, how many patients do we see with rheumatologic complaints, either joint abnormalities, chronic pain, fibromyalgia, who also have poor sleep quality. Neurologic disorders that predispose to insomnia include neuromuscular diseases, dementia, epilepsy. Even dermatologists can have patients with insomnia because they see patients with chronic itching disorders, which can be actually very disruptive to sleep quality. And I think we recognize the urologic disorders that cause insomnia and the psychiatric issues, including alcohol or substance use. So when we see these patients, I like to take kind of a systematic approach to asking them questions about their sleep. And ultimately, these patients sort of line up in like three different categories. Either they have no comorbidities, really insomnia is their only complaint, or they have medical comorbidities that we'll talk about in a minute, and we just mentioned, or they have psychiatric issues that contribute to their poor sleep quality. So when I talk to patients, I say, look, let's think, we have like 5 big categories of things that might make you sleep poorly. And let's go through those systematically and see if you fit into any of these categories. So the first is we want to make sure they actually don't have a sleep disorder like sleep apnea or like periodic limb movements of sleep, or another thing called REM behavior disorder. There's also the condition called restless leg syndrome, which, kind of gets pushed over to the sleep world, but is actually not a sleep disorder. It's a restless legs phenomenon in the evening usually, but that can also contribute to sleep onset insomnia. So patients with breathing complaints or patients who can fall asleep easily but wake frequently during the night, you got to think that they could potentially have sleep apnea as a contributor to that, or they could have excessive motor activity, what we call periodic limb movements of sleep that are contributing. But if you put that category aside, then we're talking about assessing the patient for medical problems or chronic medications that might interfere with sleep. The third category is the environment for sleeping, and I'm going to talk about that a little bit more because I think we probably don't question the patients enough about who they're sleeping with and what kind of room they're sleeping in and how that plays into their sleep issues. The fourth category is this sort of most common, I would say, cause of insomnia, which is what we used to call psychophysiologic insomnia, where again, it has to do with the cyclic vicious cycle. The more insomnia you have, the more insomnia you have. And finally, the fifth category is there an underlying psychiatric disorder that's actually causing the poor sleep? So, there we go. So, as I said, people with insomnia due to obstructive sleep apnea, they typically fall asleep okay, but have difficulty with the maintenance of sleep. And again, they complain more of somnolence during the day, not just fatigue, but actually, being sleepy in sedentary situations. I mentioned about the limb movement disorder. I mean, narcolepsy, we tend to think as more of a daytime phenomenon with the excessive sleepiness, but narcoleptics actually have very vivid dreams and frequent, like very almost, psychiatric type dreams. And so if the patient comes into you and says, hey, I'm not sleeping well and I'm dreaming all the time, like very vividly, you do need to question them more about the possibility of having that disorder. Another thing I want to point out, a very common phenomenon that we see particularly in younger patients is what we call delayed sleep phase syndrome. And I'm sure all of you have experienced that in some form, usually in college, where you delay your sleep time till 2 or 3 or 4 a.m. And then you think you have insomnia because you're not sleeping well and have to get up early to go to class or whatever. That's actually not insomnia. That's a timing disorder or circadian disorder. But some patients present as if they can't sleep well, but actually when you question them, it's that they can't fall asleep till 2 or 3 a.m. And if they were allowed to sleep till 10 or 11 a.m., their sleep would be totally normal. And I do want to say a word about REM behavior disorder, because this is another one of these things that we in the sleep world see not that infrequently. And I think people in primary care should recognize this. So REM behavior disorder is typically a disorder of men, older men, who do perceive poor quality sleep. And but the hallmark of this is they enact their dreams. And what this means is they'll punch the wall, or they'll punch their spouse, or they'll fall out of bed because they're, instead of in REM sleep where their muscles should be paralyzed, they're actually enacting the dream sequence. And this is associated with some neurodegenerative diseases like Parkinson's. But again, sometimes patients are not really willing to tell you this, that they hit their wife during sleep or they fell out of bed. And they come in complaining more of this poor sleep insomnia phenomenon. And this is where you have to dig a little bit more in your history and ask about dreaming. And besides the neurodegenerative diseases, some medications can cause this, particularly antidepressants. So it really should be on everybody's radar screen as a relatively rare cause of poor sleep continuity. So there's a whole bunch of medications, and I think, sometimes we don't do a very thorough job at reconciling those medication lists and sort of peering through all the medications that the patients may potentially be taking. But SSRIs typically are not very helpful for sleep and sometimes can cause sleep disruption. The anticholinergics and the other Parkinson's disease medications can be very disruptive to sleep. Clearly, Adderall taken at 4 p.m. is not going to be good for your sleep. So you need to question patients about if they're on stimulants and the timing of the time they take those drugs. Steroids is another one. I mean, I think somewhat under-recognized as a contributor to insomnia. And of course, alcohol. Alcohol tends to make people sleep initially, but then sleep poorly in the second half of the night. And so you really need to question patients when you see them and they're complaining of this, about what drugs and what over-the-counter medications. Another class of drugs, maybe a little bit under the radar screen, is decongestants. I'm sure you all realize that drugs like pseudoephedrine can also contribute to insomnia. So close questioning of the patient really is important in getting a good sleep history and insomnia. Now, moving on to that category of poor sleep environment, I've sort of learned over the years that you really do need to ask the patients about this, because some of the crazy things that patients do, there's fair number of patients that never sleep in a bed. They sleep on a recliner all night, or they have 5 cats in the room, or they sleep with the cat on their head, or the 3 dogs that have to get up in the middle of the night because they're old and they have to go out, right? These are things that are very practical questions, and actually should be asked, because sometimes you can fix people's sleep quality just by talking to them about their environment for sleeping. And there's actually a paper on this looking at why it's not a good idea to share a bed with a dog, at least, because dogs have different sleep cycles than humans. So dogs usually cycle through sleep-wake 3 times per night, and we don't do that, right? So the dog is usually waking you up. And I have to say, like, I really don't like cats. I can't believe people sleep with cats on their pillows and stuff. But the cats with their dander and make you cough and make you sneeze during the night, not a good idea. But there's other things, right? Untreated sleep apnea, the spouse who has to listen to the other spouse who's snoring away. The solution to that is both of them wearing CPAP if they both have it. It's interesting because there is a literature on this whole issue of sleeping in 2 different beds in order to avoid some of the problems and pitfalls of sleeping. So again, some practical things that just really should come to mind when you're talking to the patient. And then that category of psychophysiologic insomnia is this ruminating, intrusive thoughts during sleep. You wake up, you're thinking about, what you have to do today, how things didn't go well yesterday. That is a very common phenomenon when we're dealing with patients with insomnia. And finally, again, the chicken and the egg. A lot of patients come in and say, hey, this insomnia is making me depressed. But, sometimes it's the opposite, right? The depression is causing the insomnia. So that needs to be questioned as well. So how do we do this? I mean, it's really all about talking to the patient and sort of keeping those categories in mind when you're taking your sleep history. I tend to ask patients with well-established insomnia to kind of run me through what they do during a usual 24-hour day. So not just what they do at night, but what goes on during their day. When do they eat? When do they exercise? Because those things can impact, again, the quality of their sleep. We often ask patients to keep a sleep diary, and I'll show you an example of that. And then we'll talk a little bit about these these wearables, and what role they might have in insomnia. And finally, we don't usually need a sleep study in patients with insomnia, unless we suspect that they have sleep apnea based on their history or maybe a movement disorder. So this is, you can't see it all that well, but this is a typical sleep diary. I mean, it's very self-explanatory. What time did you wake up? What time did you go to bed? What did you do during the course of the day? What time did you eat? Did you drink any alcohol, et cetera, et cetera? So these can be helpful in sort of setting the stage. And I actually find sometimes this just helps the patient like organize their thoughts about why they're not sleeping well. They just, like, if you look at it on paper for a week or two, sometimes patients like realize, geez, I'm doing something wrong here, and I can probably work on fixing this myself. So I find sleep diaries helpful in helping me and the patient sort out some of their sleep issues. Now, it's funny because for 25 years we had these things called this thing called actigraphy, which was a wrist monitor of movement, right? And you can see the thing up on the top right. It's kind of ugly and has a clock on it, and you wear it on your wrist. And the point of this was to determine like when you were moving versus when you were not. And the sleep part of your cycle is when you're not moving, right? So, and we could never get insurance companies to pay for these things, blah, blah, blah. And now, lo and behold, everybody has one of these devices that's just fancied up, right? And looks a lot nicer and is kind of cool. But in truth, they're really just movement monitors for the most part. So I was going to talk about these 3 of the big ones. Has anybody tried this Oura ring? Or will you admit it? Amazingly, they have a partnership now with Gucci, and there's a Gucci Aura Ring down there on the bottom left. They are advertising that on their website. So they're making it look really good. So, Aura is claiming, a lot that they can determine you're awake versus asleep, but also what stages of sleep and how much % of your sleep is in each stage. And there's, it's nice, and they give the patient this fancy report on their phone, but the accuracy of this is kind of questionable. And likewise, the Apple Watch, right? The latest Apple Watch does a similar kind of readout for the patients. And, patients come in with this, right? They're like, look at this, or look at what I downloaded, and I'm only getting, 10 minutes of REM sleep. And, my sleep quality rated by my watch is poor. And then there's the latest Fitbit, the Charge 5, which also, it gives you things that I wouldn't even think of, heart rate variability during the night. I mean, I know that's like a cardiac thing, but it's not like a sleep thing very much, right? And how many breaths per minute you breathe all night long, right? This is with Fitbit. So where do we stand with this? Like, how can this help us, or does it hurt the patient in a way to be sort of hyper attentive to their wearable? So there have been studies where a patient wears one of these devices, and I cited them here, where they, in the sleep lab, right, they wore the, most of them been with earlier models of the Apple Watch or the earlier models of the Fitbit. So it turns out these things are quite reliable in telling sleep versus wakefulness, because again, they're movement monitors for that, right? But they are not reliable in determining, hey, the patient has, an hour of REM sleep or an hour and a half of deep sleep. They're not good enough for that. In the sleep lab, obviously, we use the EEG to determine that. So you don't have electrodes stuck to your Apple Watch to your head, right? I think in 5-10 years, there'll probably be better sophistication on this, right? But right now, they are helpful in terms of, sleep versus wakefulness, but really not in coaching the patient, hey, I can give you another hour of REM sleep or whatever. And an interesting paper that was published from Rush in 2017 talked about this phenomenon of orthosomnia. And they made that word because of orthorexia. And this is like a preoccupation with, these devices, basically. With the rexia, that's for healthy eating. But this sort of preoccupation that I have this competitive thing with my spouse or whatever about my sleep quality. So I've found this a lot. I think my colleagues would probably agree that people like over focus on these devices to the detriment of their sleep. They're just like attached to it 24/7, and really think their sleep is terrible because of the readout. And it probably, in some ways, at least right now, is somewhat of a disservice. But can we use this in some diagnostic fashion to reassure patients that they actually are sleeping, or how many hours that we're sleeping? I mean, maybe yes, but we're not giving them out. Again, it's the irony, because we could never get insurance companies to pay for these movement monitors, and now everybody's just buying them themselves. So I think more to come on this issue. It's kind of cool and interesting, but not yet ready, I think, for prime time and sleep. And finally, in terms of diagnosis, I already mentioned most patients with insomnia really don't need a sleep study. Sleep study, of course, in the sleep lab is, it's not invasive, but it's intrusive because there's 16 different sets of monitors on the patient. The home sleep study that we do commonly now is really just designed for looking for sleep apnea. So there's really no reason in a patient who's just insomniac to have a home sleep study. But an in-lab sleep study is usually not of great help in the sort of run-of-the-mill insomnia case. So I'm going to finish up by talking about treatment of insomnia. And, I tell the patients this is kind of a three-pronged approach, right? One is behaviors that they can modify themselves. The second is the concept of cognitive behavioral therapy. And the third is medications. But, so general patient education, sort of already, you can guess, allude to this, like the watch, and you should put that aside, and talk about the avoiding stimulants at night, including over-the-counter medications, sort of adjust their schedule, their sleep hygiene in terms of a wind down period at night, kind of relaxing and then going to bed. We'll get into that a little bit more. We'll talk about cognitive behavioral therapy. For some patients, bright lights in the morning will help them entrain better with their internal circadian rhythm, and sometimes that can be a help in dealing with insomnia. So let me just say another word about sleep hygiene. So some of the things that we stress with patients seem a little counterintuitive to them. And one of those is what we call sleep limitation. So the idea of this is if you're not sleeping, you should get out of your bed and break the association between your bed and not being asleep. And that's a hard one for patients to kind of buy into. But the concept of kind of looking at your bed and not being able to sleep sometimes is helped by that stimulus control or sleep limitation. You want to tell patients not to nap, to have a consistent bedtime and wake up time, and to try to do some kind of relaxation therapy as well. The best treatment for insomnia is in some ways the hardest one to access, and that's cognitive behavioral therapy. And again, this is a whole set of therapies aimed at reducing the stress and the anxiety around sleeping and incorporating some of those sleep hygiene techniques. Unfortunately, there's not a ton of therapists, psychologists who are trained in CBT, and probably it's hard to access that kind of mental health care here in DC. So there are apps for that, right? And the one I usually recommend is this one called the CBTI Coach, which comes from the Department of Defense and Stanford and the VA. It's quite involved. The patients have to really sort of buy into the process of filling out the stuff on the app. But this is really considered to be, based on the literature that we have in insomnia, to be the best treatment for insomnia. And then some other of these like kind of brief therapies are usually not as good. And sleep hygiene by itself is usually not enough. So patients need this CBT in some format to really get the best results. So then, like I said, arm one of insomnia treatment is teaching the patients behaviors they can modify. Arm two is CBT, and arm three is medications, right? And we really want to minimize the need for medications. And many patients come in and they don't want to be on medications, right? But after you offer them the other things, sometimes we do have to resort to medications. And if you look at the literature on pharmacotherapy for insomnia, I mean, it's interesting because what's a successful result? Maybe 20 minutes more of sleep on a sleep study, between zolpidem and no zolpidem. So there's more to it than just the duration of sleep. There's the medications, I think sometimes just have a placebo effect, plus, some of the relaxation that comes from these medications. But really, there's not strong evidence for any of these medications that we use for insomnia. But there are, 6 categories, if you will, of medications that we can choose from. And, of course, the non-benzodiazepine receptor agonists, which are the zolpidem, the Z drugs, as we call them, zolpidem, Zalopon, are, the most prescribed, but they carry their risk, right, of tolerance and needing to take more to get the same effect, and confusion at night, especially in older patients. There's the old benzodiazepine category, which we don't use all that much anymore. A lot of sleep medicine is about using sedating antidepressants, so not the SSRIs, but the older antidepressants that are somewhat sedating. They're not ideal, and I'll talk about that in a minute, but they often do help the patient. There's melatonin and melatonin receptor agonists. And honestly, melatonin is kind of disappointing as a sleep aid. It's good for jet lag in many patients, but actually for insomnia, it's really not generally that effective. There is another class of drugs that's relatively new called orexin receptor antagonist. And then some patients are put on antipsychotics to help them with sleep. So this is the long list of the Z drugs. And there's like every different form of Ambien out there. There's like under the tongue Ambien, there's spray Ambien, there's all kinds of Zolpidem variations that are out there. On the benzodiazepines, honestly, we just really don't use these very more, although the American Academy of Sleep Medicine says that some of the shorter acting ones, like triazolam and temazepam, are reasonably effective. There's the histamine receptor antagonists, and then melatonin, and then these orexin drugs, of which there's now 3 on the market. So what does the American Academy of Sleep Medicine say? Again, cognitive behavioral therapy is the #1 treatment. They say the evidence is weak, but the benefits outweigh harms for these types of drugs. So we're talking the Z drugs, as I mentioned, the escitalopram, the zaloplan, and the zolpidem. I mentioned temazepam. The sedating antidepressant that actually the ASM recommends is doxepin. And doxepin is an old antidepressant. When it was prescribed for depression, it was like 100 or 200 milligrams. The dose we use in insomnia is 3 to 6 to 10 milligrams. So this actually is on the list of recommended sedating antidepressants. There's a melatonin agonist called Romeliton. It's on the, it's a prescription drug. Again, I don't think it does anything. And then there's these orexin receptor agonists, and the one is the one that's been around the longest is suvorexan or Belsomra. Again, the utility of it is not entirely clear. So what the ASM says potentially is harmful for patients, and ironically, this is probably the one we use the most, which is trazodone as a sedating antidepressant. I mean, all of us who do this a lot prescribe a lot of trazodone, even though the ASM says it's really not that great a drug. And then other things that they say are weak and may have some harm, as I mentioned, the benzos, and then some of these over-the-counter or natural remedies for insomnia. As I said, the melatonin agonists are generally not all that helpful. I really think it's my editorial thing of why it's on order sets in this hospital to help people sleep makes pretty much no sense at all. If melatonin is going to be helpful, you usually need to take it 2 to 3 hours before the desired bedtime in order to help and train your circadian rhythm. So not my favorite. And I know some people in this audience have prescribed antipsychotic drugs for the treatment of insomnia. We certainly do it in the ICUs. The risks of side effects are definitely there, so I would not recommend any of these drugs like quetiapine or risperidone as a first-line insomnia drug. And finally, another drug that I think we use, although the ASM says we shouldn't, is gabapentin. And, gabapentin is good for a lot of things, maybe, all unlabeled by the FDA. But again, the evidence for its effectiveness in sleep is really not there. So the bottom line on medications, of course, is, we try to go with those first 2 arms of therapy first. But if I was going to choose a drug for patients that I see, I usually go with a sedating antidepressant. And I've been using more doxepin, but we still, of course, use trazodone. We have amitriptyline, which is old, but has sometimes effective for patients. And then mirtazapine is another sedating antidepressant. And this is often a drug we'll consider patient is also underweight because it helps insomnia, but it also tends to cause some weight gain, which is, good for some of these elderly patients who have chronic insomnia. And then, we might consider the suvorexant or the Z drugs. So just run through a couple of cases real quick. This is the sort of the gamut of patients that we see. This is a healthy patient, right? No comorbidities. she's using the dreaded NyQuil at night to help her sleep. And, can anybody tell me what's actually in NyQuil, right? The sleep part of it is the Benadryl part, right? So a lot of these, almost all the over-the-counter sleep aids like Tylenol PM, Motrin PM, the component that's the sedating part is the Benadryl. So often patients will pick up on that. This kind of patient says she hasn't slept well, began in adolescence. She's not hypersomnolent, but she's very fatigued and lacking focus during the day, but she's otherwise healthy. So in this patient, like my workup is like a really detailed history, run through their daytime routine as much as I can. I might consider some kind of activity review, sleep diary. And I really try my best here, right, to teach patients good sleep behaviors and to get them to buy into the CBT concept. And then if I'm going to use medication, again, I would consider as my first line something along the lines of a sedating antidepressant. Here's another scenario that we see fairly often. This is somebody who's, an older male who is, again, pretty healthy, is on kind of the usual cholesterol, blood pressure medications, but he's been taking Zolpidem for the last 20 years to help him sleep. And we get these referrals a lot, right? That, hey, the patient's been on this for 20 years, is getting older. The insurance company says he shouldn't be getting this. We have to limit the prescribing. What do we do in this circumstance? And I tell you, I think these are like the toughest questions that we have to try to get patients off sleep meds, that to wean them off and try to get them onto something else that might be more desirable in terms of side effects, especially as they age. So they're, obviously I've sort of downplayed the Zolpidem type drugs, but they are the most commonly prescribed insomnia drugs, and they do work very well for acute insomnia. But a lot of times patients will wind up on them chronically. And as much as we try to substitute one of the other classes of drugs, we often struggle to get these patients off the chronic thing. But clearly, as you age, these sedating hypnotics can be very problematic for the patient. Certainly, if the patient starts mixing it with alcohol, and has confusional arousals or gets confused, or if they're on the start of a cognitive decline and you have these drugs still in place, you really have to try to do your best to get them off these drugs. And lastly, again, the phenomena I think we're seeing more on the Oura Ring phenomenon, or the Apple Watch. Patient says that she's middle-aged, sort of postmenopausal. Her sleep is poor. There was no obvious trigger. And the Oura Ring is telling me, my heart rate variability is not right or something. Again, I think just want to leave you with the message of this triple therapy, right? The education of the patient about good sleep behaviors, the role of cognitive behavioral therapy, and potentially medications. And I'll just leave you with this thought. This is a little off the insomnia talk, but I found this paper. I thought it was interesting for house staff consumption. This was a study done at University of Michigan where they took 33 of their med school graduates who were staying for their residency at Michigan. And for the 2 months before they started their internship, they had them wear a wearable. It was mostly Fitbit on this trial. And then they continued to wear that activity monitor for the first 6 months of their internship. And they did some, questionnaires, mood questionnaires and stuff like that. So I guess it's no big surprise. I was surprised, actually, the loss of sleep was only 2 hours and 45 minutes per week compared to June. I thought it was going to be per night, but it's actually per week. Michigan must have a very favorable environment for their first 6 months of internship. But some of the other things they found was that, and no big surprise, right? The subjects here whose sleep was short reported worse moods during the day, and short sleep seemed to affect mood more than mood affecting sleep. So Clearly, insufficient hours of sleep is impactful on how you feel during the day. And no big surprise, right? Shift working interns had worse sleep quality and shorter sleep than when they were not on shifts. So this is my wellness message for short sleep, not really insomnia, right? In our field here, to work on getting adequate sleep and don't over rely on your Fitbits. There's a whole literature on this, like orthopedic residents versus medical interns, and who takes more steps in the hospital. It turns out it's the orthopedic residents in certain environments. So there's a whole stuff on Fitbits, and you guys could do some nice studies on this. So just to conclude, I mean, this is a common disorder. You see it across the whole spectrum of medical specialties. When you evaluate the patient, it really boils down to doing a thorough history, and some aids that can help are the sleep diaries and maybe the wearables. And when it comes to therapeutics, I mean, you really have to present the patient with these 3 types of therapies, behavioral things that they can modify, the cognitive behavioral treatment, and then potentially medications. And of course, we're here to help, but there's a lot more insomnia out there than we can see all those patients. So thanks, and I'm happy to take some questions.